congenital heart defect patient. I have tetralogy of Fallot. I just turned 40 in July, and I love to see all of the things that have transpired over the years. And it's just going to get brighter, and it's just going to get better for our kids. But I want to introduce to you the next speaker. She is going to give a fabulous talk. So as you continue to just make your way in, just keep your ears open because you'll want to hear this one. Her name is Dr. Sood. She is from the AI Nemours DuPont Hospital for Children. She is a pediatric psychologist and the assistant professor of pediatrics at the Thomas Jefferson University. She directs the Nemours Cardiac Learning and Early Development program and trains psychology residents and fellows in the specialty area of cardiac neurodevelopment. She also researches and focuses on neurodevelopmental outcomes, developmental care, and family psychosocial interventions for congenital heart defects. So please, let's welcome her. And if you have any questions, I think we are waiting to the end. But are you ready?
I'm just going to pass along as well that anyone who wants to go to the bereavement session is next door. You got it correct. Well, first of all, I just want to say I'm very, very excited to be here. Thank you so much for inviting me. Should I use that one? Yeah. Okay. Should I give you this one then? Perfect. Okay. Can everyone hear me? Okay. So I'm going to be talking today about collaborating with parents and providers to improve family-based psychosocial care with a specific focus on the CHD Family Support Crowdsourcing Study. I'm going to start with a review of the research on parent stress with CHD and make the case for the need for community-engaged research to improve supports for families of children with congenital heart disease. And then I'll spend the majority of my time on the CHD Family Support Crowdsourcing Study. I'm just wondering, is there a way to make this thing right here go away? Okay, I got it, never mind. Just couldn't see half my slides. So whenever I present on parent stress, especially to a group of parents, okay, sounds good. I always like to start with some quotes from parents because you're all the experts, not me. So these are 3 quotes that I particularly like, but I picked them out of like thousands that I have. And so there's many good ones from parents who have a child with a congenital heart defect. And the first one is from a parent who's talking about the experience of receiving a postnatal diagnosis of CHD, and I'll read it out loud. I'll never forget when I heard him say that she needed open heart surgery. I was sitting in a high back chair and my head just hit the back. The news was just overwhelming, completely overwhelming. This is a quote from a parent who's talking about their experience in the cardiac ICU. Not being able to hold him for like a month after he was born. I was there day in and day out. I stood there and watched, him crash right in front of me, and I just had to step away from the bed and let the doctors just rush to him because there's nothing I could do. And then the last quote I think is important to demonstrate that there's not really a close relationship between the kind of severity or acuity of the heart defect and parent stress or traumatic stress. And I think providers often think, oh, that family should be fine. Their kid's doing great. And that's just not true. So this is a parent who has a child with a VSD, went through VSD repair, child is 3 years out, doing wonderfully, and the parent's talking about waking up 3 to 4 times a night every night to check on her child. It does something to you not knowing if you're going to wake up with their baby the next morning. I get up 3 or 4 times a night to check on her. I have to. It's just something I have to do. I have to make sure she's okay. And when I talk about parent stress, it's sort of just an easy way of describing all of these things that go into parent stress. So I don't want to have to say every single one of these every single time, because that's why I say parent stress. But we're really talking about that initial feeling of shock at diagnosis, and also probably every complication after that, feelings of self-blame, feelings of isolation, changes to the parent role, traumatic stress, both acutely during that crisis period as well as long-term, financial stress, that day-to-day burden of caring for a child who has many medical needs. And what we know is that about 1/3 of parents experience clinically significant traumatic stress, anxiety, and depression. More than 1/3 experience symptoms, but about 1/3 of our population of families is really struggling with mental health challenges. And what is a little bit different about CHD compared to some other more traditional traumas is that the stressor never goes away. So as parents, you hear, your child will need lifelong care. we're just going to monitor, we're going to wait and see. And so what that means is that there's never kind of a post. It's sort of chronic traumatic stress. We've also heard from parents that emotional symptoms can present at unexpected times. And so I think from the healthcare side, oftentimes providers say, well, once they're home, everything's going to go back to normal. In some cases, not in all cases. And I think parents have said that's just not true. It's actually a year later or 6 months later that it hits us. We were numb and in crisis mode when we were in the hospital, and it's actually later we need support. And at that point, the support from that healthcare team may not be as easily accessible. And that's obviously where groups like Mental Hearts come into. So why are we spending so much time talking about parenting stress? Obviously, most parents are saying, I just want to make sure my child's okay. But we know that parent stress impacts the mental health and wellness of the family and eventually child outcomes. So parents who are struggling more with stress when their child is 1, 2, 3, and 4 years of age predicts child emotional and behavioral problems at age 4. Traumatic stress impacts general well-being of children and adolescents. It impacts psychosocial health. And there's some preliminary evidence to suggest it may even impact neurodevelopment. We don't know yet what the effects of kind of parent and family well-being are on child physical health. So there's good news and bad news. The good news is that there have been researchers in congenital heart disease, although less so. The only 2 studies I know of that have looked at an intervention in a controlled way for family stress and coping are actually in Ireland, I believe. But there have been a lot of studies looking at kind of the effects of family psychosocial interventions and really showing that they can reduce stress, they can help families to cope better, and they can improve child outcomes. The not so good news is that as of now, we don't have any of these in the United States for congenital heart disease. And we also don't have any formal standards for the care of families of children with congenital heart disease. So in 2015, Pediatric Blood and Cancer published an entire issue on standards for psychosocial care for children with cancer and their families. Same year, Journal of Perinatology published, I think it's half an issue on psychosocial program standards for NICU parents. We have nothing like this in congenital heart disease, not even close. We have no formal recommendations, no standards, basically nothing published. So I strongly believe that collaboration is needed. We have an opportunity to work together as providers, community leaders, and CHD parents to develop programs and tools to better support families. And what's really important is that these programs and tools must be acceptable and feasible to all stakeholders. So if a group of psychologists gets together and says, this is how we support families in the ICU setting, but the ICU intensivist doesn't agree, well, we're getting nowhere. Similarly, if a group of parents talks about it but doesn't have the buy-in from the mental health staff, so everybody has to work together on this. So the CHD Family Support Crowdsourcing Study received grant funding in December 2016, for about 9 months in. And this study aims to engage parents, leaders of CHD organizations such as Mental Hearts, as well as several others, and healthcare providers from across the nation in the development of a psychosocial care model for families of infants with congenital heart disease using online crowdsourcing. So to break that down, when I talk about a psychosocial care model, it's really just a fancy term for formal plan recommendations on how to better support families. And this is really in all settings. So supporting families during that initial diagnosis, supporting families in the ICU, and the step-down unit at home. Obviously, that's a complex goal, but it needs to happen. When we talk about crowdsourcing, we're talking about the process of generating ideas, solving problems, and producing results by soliciting contributions from large groups in the form of online communities. So this is a community-engaged research project. We've had community advisors from the very beginning. A couple of these people were actually involved with the initial grant application. So we have folks from several different organizations that are involved. We have clinician and researcher advisors from 4 different institutions. Our advisors are psychologists, social workers, intensivists, nurse practitioner, CICU nurse, and then a couple of researchers. And our stakeholder advisors are very involved. So we have conference calls twice a month. We have many emails going around all the time. I ask a lot of them, but really I need their help in terms of making decisions about study methodology. How are we going to recruit? How do we handle this challenge that came up? What should we do about that? What domains do we want to even ask about? What's important? How do we word the questions? So they really give feedback on all of this. And then, of course, they're going to be helping to develop the model as well. So I'm going to talk just for a few minutes about methodology. We have currently two stakeholder crowds from across the United States that are responding to questions posted on Yammer, which is a private social networking site, about best practices, gaps, barriers, and opportunities in family-based psychosocial care. Mothers and fathers are from diverse backgrounds. That was very important to us, that we made sure that we heard all different voices. And then we also have leaders from CHD organizations. And crowd participants can view responses of other members of their crowd, and there's the potential for interaction between the crowds. So we wanted to be transparent. I mean, the data that we're collecting is not, there's nothing private about it or secret about it. It's anybody who's on that website who's participating in the study can go through and read as many or as few of them as they would like. I would say in the beginning of the study, we had many more people sort of liking each other's responses and responding to each other. I think as the study goes on, you know, for our parent crowd, we have 106 parents. I think people don't have the time to be reading 106 responses every week, but they can if they want to. And then our future queries that we ask, the questions we ask are informed by past queries. And so what I think is important here is that this is not a survey. We did not send out a survey of 30 questions to our different crowds and say, answer these questions. We started with really broad questions to both crowds, and then worked from their responses to then, you know, write the next set of questions, the next set of questions. And so even though we did start both crowds with ideas of what we wanted to ask, we had to have some guide here. We've cut out questions, cut out entire domains, added questions because it's become apparent that we don't need to ask about something because people are already talking about it, or that's not as much of an area, you know, opportunity. Maybe that's already sort of been addressed. So this is just a screenshot, a couple screenshots from Yammer. So question one, this is the first question that we posted to the parent crowd. What are some things you wish you had known early on about how the CHD diagnosis could impact you and your family? As you might expect, we got many, many responses about a lot of different things that families wish they had known. And then I think we had like 50 responses within, I think we had 25 within 4 hours, 50 within the first day, and we have a week-long deadline. These are the domains of psychosocial care that we've sort of come up with that we think are important. This is prior to analyzing all the data, so we may change these, but these are the things that our advisors said, you know, we all sat down together that these are important things. So integrating families in hospital care with other active partners, having a formalized process of connecting families with peer-to-peer support so they don't just find your resources and your services randomly. Some form of mental health screening, prevention, intervention by the care team, and down to sibling-specific supports, palliative care, grief and loss, and then also how to promote resiliency and protect folks from secondary traumatic stress and vicarious trauma. So what happens is basically we extract all of the posts out of Yammer and they become qualitative data. So it's different than if you think about most studies that are quantitative, you're going to see statistics and p-values and numbers and percentages. This is different. This is basically looking for common themes. So we get all the responses. It's going to be about 3,000 responses. We're going to put them into de-identified into a qualitative analytic software program, and then we're going to go through and literally code and assign labels. So this one has to do with sibling support. This one has to do with something that someone wished they'd known about the emotional impact, so that when we want to make sense of that, we can just pull all those responses. So it's just a way of sorting the information. And then the themes that come out of this will inform the development of a family-based psychosocial care model. And then when we have draft, like a summary and recommendations, we're going to put it back to the crowds. We'll put it back to the community leaders. We'll put it back to the parents and have questions about what do you think, what do you need to change, what isn't acceptable or feasible. We're also at that point going to form a third crowd of healthcare providers to have them comment on those recommendations. Our initial plan was to have the healthcare providers from the beginning, but we realized that really what was important is what do the parents and the leaders want? And then we can have the healthcare providers comment on, well, what are the barriers, what's going to get in the way, why hasn't this happened already? And that was really the most important way to involve them. So just briefly, our CHD leader crowd has 16 leaders participating. We had more that signed consent, which is all done electronically, but people kind of drop off at various stages of kind of getting set up on Yammer. And so we ended up having 16 that actually participated from 5 CHD organizations, ranging in size and scope. The majority are female, as I think is probably pretty typical of leaders from CHD organizations. We have some diversity, not as much as I would have liked to see, but some, and so that's something to work on. In terms of the parent crowd, we actually got a really nice diverse sample. So we have 106 parents who actually participated. Of that, we have 30% of those are dads. We had to do extra calls out for dads, but we have 30% of our dads participating, which is awesome. And we have pretty equal from different parts of the country. About 50% are in suburban areas, but we do have another 25% in urban and rural areas. We did have to, unfortunately, turn people away because we wanted to have a diverse sample and we didn't want to get too far over 100, just to be able to manage the data. And so we did have to unfortunately turn people away if they were in a group that we just had, for example, college or graduate level education. We just had too many people who were interested in participating. About 50% have had a single ventricle palliation that their child has had. We have some diversity in terms of race and ethnicity, 17%. Again, an area for future opportunities to determine how best to engage ethnic minority participants, as we know that CHD impacts all of the people from all different backgrounds. So I'm going to spend the rest of the time just talking a little bit about what we've learned so far. What I want to point out here is that this is not based on any analysis. We are not done with the study yet. We have not coded anything. This is really just based on me. We're quite familiar with the responses at this point. We read them all the time. Some things that have popped out. We will have a much more detailed summary and recommendations once we're done, which will be hopefully winter or early spring. So an overwhelming response from the parents were that parents want enhanced preparation, not just for this is your child's heart defect and this is the surgery that he or she will need, but that this is a marathon, not a sprint. Your life won't get back to normal when you leave the hospital. A little more information about some of the common complications, more preparation for the financial and emotional impact on the family, more preparation for the developmental and feeding challenges that children often face. That I think many parents said, nobody ever told us about this, or we weren't prepared. Parents want a formalized process for early peer-to-peer connections. So it seems like many of the parents in our sample have connected, but partly that's because we recruited through social media as one of our sources, and so I think there are probably many parents that aren't connected yet. But parents definitely said that they would have liked those connections to be facilitated a lot earlier, as early as possible, and ideally by the care team in a sort of a structured way. And that doesn't mean that every family is going to follow through and contact them that day, but that they would have liked to have that information. More CHD awareness. I think we all know that that's a goal, but I think as it relates to how the initial diagnosis was delivered by a community provider, for example, and maybe folks who maybe weren't as up to date on some of the most recent research, as well as responses from family and friends. Parents would have liked to receive information during that initial diagnosis consultation, not with the cardiologist even, but when they were first told by an OB or a gynecologist or a pediatrician that something might be wrong with the heart, to have even just a pamphlet to go home with on what are CHD, because they're often told, don't Google, well then what am I going to do? I don't have any information then. The parents said that they would have liked care team to be more understanding of the stressors and demands outside of the hospital, so that a family's life is not only existing within the hospital, there are other things that they have to take care of outside of the hospital. And also that the stressors might change with the CHD diagnosis. So just because a family is financially stable when they're first admitted, that doesn't mean that they are 6 months in when maybe one parent has had to leave their job, and that they would have liked more sort of support around that, but also kind of more conversations about it at various time points so that they can be connected with resources that may be available. Encouragement for parents to partner in their child's care while also understanding that parents can't be in the hospital 100% of the time typically. Care team understanding the emotional impact of CHD. Many parents talked about feeling like they didn't quite feel like the care team understood how lonely this was, or how guilty they felt, or how much they grieved. And then availability of mental health supports. And I think this one is the most recent set of questions we posted, and this one is probably the most interesting in that it is very split in terms of what parents want. So we have some parents that are saying counseling should be mandatory, this should just be something that's part of the care, everybody has to go through it. And to take a step back, every parent said that had an emotional impact. It was just how they wanted the care team to help to address that. Some parents said, well, if somebody had asked me, I would have talked about it, but it didn't really think it was their role and they didn't ask, they didn't seem that interested. And then the other set of parents said, I don't really want them to ask me about my mental health because I want them to focus on my child. It's not really their business, and I can sort of find supports outside of the hospital. So very varied responses, but everyone felt, I think, pretty passionate about what they said. And so I think it's going to be a challenge to figure out how do you meet the needs of families who are coming from a variety of different perspectives with regard to mental health supports. So CHD leaders have wished for more resources for CHD organizations, more recognition of all the volunteer time and efforts that are put into running these organizations, and that would allow for more supports to be given to families if the leaders were actually getting more, they were getting more donations, if they were getting more support. Greater CHD awareness, again, as it relates to more donations, which then equals more supports for families. Many leaders commented on the difference in sort of awareness for conditions like pediatric cancer and CHD, and feeling like if a donor is going to give, they're likely going to give to pediatric cancer because they've heard of it. More effective collaboration across organizations, and then also with care centers. So some leaders mentioned that the care centers may give out their delivery bags or may allow them to have a table at an event, but that they really want much more than that, which is the ability to sit down and work with the care team on how can we work together to best support the family. The ability to offer more specialized supports, so supports that are maybe specific to siblings, specific to dad, specific for bereavement. Formalized training and education regarding mental health issues. So, I think all the leaders said, parents open up to us more than maybe they're going to open up to their hospital social worker or a care provider because they think they know we've been there, we understand. But most CHD leaders don't have formalized mental health training, nor should they. That's not your role. But it is important to know what are the warning signs for we got to get this parent some real mental health support. How do you have those difficult conversations about mental health needs that I think it's time, I will still be here to support you, but I think it's time that you also find professional help. Understanding what the mental health resources are in your area. It can be extremely difficult to navigate. Often the resources are terrible. And so how do you navigate those and know where to send families when a parent is open to receiving this type of support? And then crisis management, at what point do you need to send somebody to the hospital? Call 911 or call a crisis line. And then lastly, training and resources to promote resiliency and prevent burnout among CHD leaders. So obviously people go into this work because they're empathetic and they want to help, but it also means that you're faced with a lot of other people's trauma. And how do you continue to do your work and not burn out, and continue to be effective and supportive to others, and know when you need to take a break also. So this is by no means everything that we've learned. We will have much more, but these are sort of the obvious things that I could get from just reading through the responses. So in terms of next steps, we still need to finish our parent crowd data collection. We will be doing the formal coding and analysis this winter. We will be drafting the psychosocial care model and recommendations. We'll be putting those back to the parent and the leader crowds, also forming a healthcare provider crowd. And the goal there is that we're hearing from all different types of providers that are involved in the care of children with CHD. So that includes, physicians in the ICU, but also outpatient physicians, also step-down physicians that also involve psychologists and social workers and nurses and nurse practitioners, and it's going to be interesting to figure out how to make that work. And then we'll be basically refining the model and the recommendations based on the feedback from the crowds, and then disseminate to healthcare providers in the community. So when we talk about dissemination, we're talking about disseminating to journals, disseminating to professional conferences, but also things like this and social media, and making sure that everybody's really aware that this exists. So I'm done. I know we're not doing questions afterwards, but I'm around till 4, so if anybody wants to talk to me, I would love to talk to you all. Take care.
Thank you so much.
All right, so now we are going to, our next presenter is going to be Danduran, excuse me. And he has 18 years of clinical experience within the field of pediatric cardiopulmonary exercise testing, evaluation, and prescription of both at the Children's Memorial Center in Chicago and the Children's Hospital of Wisconsin, where he currently holds a position of senior exercise psychologist at the Herman Hart Center. Mr. Danduran's area of interest are in pediatrics, individuals with congenital heart disease, exercise, rehabilitation and prescription in chronic illness, and measures of non-invasive cardiac, I think I'm getting older, I need glasses, cardiac testing options such as near-infrared spectroscopy to assess regular saturations in response to maximum work. we're really excited to have him. So if you guys would please welcome him. And we'll do questions at the
end. All right, I'm typically not someone to use a microphone. Everyone can hear me in the back? Perfect, okay. In addition to working at Children's Hospital of Wisconsin, I flew in this morning, and it was very strange. Yesterday in Milwaukee, it was 98 degrees. And so it's strange for me to say that I came to Texas to cool off. But we did. It was miserable. And when I was leaving my house about 3 this morning, it was still like 86 degrees. It was uncommonly gross. So anybody that's going to the game tonight, it should be like very beautiful tonight, right? All right. So a little bit about me. Let's see if we're moving through here. So again, my slides are going to be somewhat comical, and it's not meant to belittle anybody. I'm not a super serious guy when it comes to this. It's just something I'm passionate about, and it's what I like, okay? So a little bit about me. I'm a registered clinical exercise physiologist, and I've been working with kids in congenital heart disease for about the last 20 years. In 1995, I took a job at the Children's Hospital in Chicago, Children's Memorial at the time. It's now known as Lurie's Children's. And I started working with kids with chronic disease. And I'll be very honest with you, in my undergrad, I had no interest in working with kids with chronic disease. I was going to work with athletes. And the reason I was going to work with athletes was, come on, that's just cool. We're going to work with athletes. So I took a job, and I started working with kids with chronic disease. And I found out very much that without hesitation, I believe that children with congenital heart disease or any chronic disease are probably some of our strongest and bravest athletes that we know. And so I've been with them now for the past 20 years, and I love it. I am forever optimistic about people's abilities. It's what I do. I'm in the business of motivation, if you will. And I'm biased because I'm a lifetime exerciser. And I say that because I think it's important, right? If you are somebody who's asking someone to exercise and you yourself love exercise, it seems very common that they would love it too, right? And for many of you, you're motivated parents and you're in this room for a reason because you want this information and you want to care about what's going on. And that's not to imply that the parents that aren't here don't. But for different interests and different reasons, I don't need to necessarily motivate you as much as I need to motivate some of the other parents to get involved with the things that we're asking them to do. So it's pretty straightforward. But there's one more thing that I am, and I'm proud to admit it, I'm a little bit of a nerd. Okay? and I get that. I love talking about exercise, and I like talking about these things because they're passionate to me, right? Very much like you love talking about your kids. And the reason that you love talking and coming to these things is because you're passionate about information and you're passionate about what you want to hear. So with that being said, we're just going to move on. So why do I believe that I'm a nerd? Well, I love information. And when I started at Children's Hospital of Wisconsin in, I think it was 2002, trying to remember, but very much like everybody in here, my memory starts to go and I'm getting a little older, all right? So when I started in 2002, we were doing about 200 stress tests a year. And now, great centers around the country, CHOP, Boston, you name it, Children's Hospital right here in Texas, right? You guys are top 10, top 5 center all the time. Congratulations for that. It's an amazing place. And they do exercise tests all the time. But in 2002, they weren't as common as they are now. So if your children are getting on a treadmill and you're doing stress tests, this is something that wasn't always the norm. So I went back and I looked at some of our breakdown. I said, what are the patterns? Well, of all the kids that were even coming, of those 200, in a heart center, only about 41% of them, or well less than half, were actually kids with congenital heart disease. When I went and started talking to the cardiologist in 2002 and 2003, why aren't you sending your kids to the stress lab? Well, I don't know what it means. I don't know what the data you're going to provide me is going to tell me. I don't know if it's really even safe for them to be doing this. These were some of the things that we were thinking in 2002. Instead of telling them the classic Bethesda guidelines, if you will, that said, your children, oh, if they have this diagnosis, they can do these things. Well, I got tired of telling people what they can't do, and I said, let's start telling them what they can do. And we changed the philosophy a little bit. And we broke that down even further. Of that 41%, we had a pretty diverse group of different diagnoses. So we were dealing with kids with aortic stenosis, VSDs, complex congenital heart disease, all the way from single ventricles to heterotaxy syndrome to you name it. So what did it all come down to? Well, 15 years later, are we better? Well, I know for sure we do a lot more tests, but what I now believe is that we have more control over the outcome because now we're telling kids to exercise. We know what this data means, and we know how to use it in the manipulation of trying to make these kids more empowered. And I use the word empowered because sometimes we can make them better, sometimes we can make them stronger, but I do believe we can empower them to feel confident. We can empower the parents to feel the same way. So my first attempt at rehab, hey Mike, I've got a patient who, right? And can you set up an exercise program for him? And I was like, okay. My first question to them, right, was, well, what do they like to do? And I was surprised. And I'm calling out some of my cardiologists back in 2002 at Children's. They're like, I don't know. Are you not talking about this with your patients? Your patients, your kids should be, that's one of the things that we should be talking about. Exercise is medicine, right? Exercise should be a vital sign. We should be asking our patients what it is that they like to do. Because unfortunately, in our adult mentality, exercise is running on a rat wheel, right? So we overcomplicate exercise in children, especially those with congenital heart disease. We tell them, well, we want you to limit yourself. We want you to stop if you feel short of breath, but we don't necessarily define short of breath. We don't define what normal is, right? When I exercise, I get short of breath. So do you, right? We all should stop, right? We should just quit completely. There we go, see? All right, that's what I'm talking about. So if we explain things to kids differently, right? When we exercise, we're making our heart stronger. It's supposed to be faster. We are supposed to breathe harder. We are supposed to get a little sweaty, right? My child turns red. Was it hot outside? It was. That's why they're red, right? Sunblock and keep exercising, right? So I know I'm oversimplifying this in some ways, but it is what we're talking about when we really think about it. So our first real attempt at this idea of cardiac rehab was just after 2014. Now, literally, I had been there for 12 years at this point, and I was trying desperately to implement some kind of program that would be organized. And we got everything from, well, we can't fund it. There's no good reimbursement for it. The hospital doesn't want to pay for such a program to try and develop these things. Plus, for the last 12 years, we've been saying, hey, Mike, I got this kid, and you've been doing a really good job of just setting up individual programs for him. Well, that became a little cumbersome, a little bit burdensome. And the reality is we were doing a disservice to those kids. So what we did is we performed a 12-week home rehabilitation study. Now, granted, have other people done this study? They have, absolutely, right? Dr. Rhodes, Dr. Paradon at CHOP, all of these really, really well-known people in the world of congenital heart disease have done exercise studies in these. Michael McBride at CHOP as well. Guys that I really look up to and what they do all the time with our patients, right? So with that being said, we wanted to just see if we could do something different. So instead of trying to bring them in, which we thought was somewhat unrealistic, right? We want you, as parents, to put your kid in a car and bring them to a place that may not always be convenient, and deal with parking and do this. Oh, and they have school and you might have a job and you might have all these other things, but we want you to be here 3 days a week. So we said, you know what? We're going to try and change the mentality a little bit. We want this to be a home-based program because, again, I'm going right back to that empowering idea, right? I want this to be a lifestyle choice. I want this to be something for you, right? And we did something else that was very different. A lot of programs would do a lot of what we call aerobic training. We're going to train their heart, right? Even though their heart may be at a disadvantage, our idea was that we were going to train it. But if you look at the literature for exercise rehab and some of the testing, we see some improvements in this idea of VO2 max or the ability of the heart to work, or we see some improvement in their fitness level, but it doesn't really equate to how much work they're doing. So we thought to ourselves, we said, we've heard talks about nutrition. We've talked about, making sure they eat. We've talked about psychosocial well-being. We've talked about psychological factors. We wanted to do something that was going to be both fun, but we wanted to do it in a moderate and high-intensity way. We wanted them to feel what it was like to breathe hard. We wanted them to be what it was like to exercise hard where their heart would be beating hard. We had 3 in-person formal sessions. Now, we could have put a mouthpiece in their mouth. We could have put them on a treadmill. We decided not to consciously. We wanted them to do the classic PACER test, which is the test that many of them do in gym class when they're at school, right? Because we wanted them to also be empowered to feel like I can go to gym class and do these tests. I want them to feel that sense of, why am I doing something that none of my friends do? My friends don't put a mouthpiece in their mouth, they don't put EKG stickers on their chest, and they don't walk on a treadmill. So what do your friends do? Well, they do the PACER test. So we're going to do the PACER test, right? Well, I'm not very good at it. That's okay. Because we're going to see if we can get you better at it, right? And so we did the PACER test. We, of course, measured health-related quality of life. Can't do anything without doing that, right? We want to know if we're actually improving something besides maybe just a heart rate or anything like that. And then we did something that was really unique. We wanted all of our kids to quote unquote have a big brother or big sister. So in my affiliation at Marquette University as an assistant professor there, I utilized our college kids, and each one of our heart kids got a college kid mentor. And they would call them once a week and just say, hey, what's up? How you doing? Did you do your homework? Did you do your exercise? Homework, yes. Exercise, sometimes no. Right? Gave them a Fitbit, a toy, right? Gave them something to roam around with, calculate their steps, do some things like that. And when we put it all together, we had this great group of kids. Yes, they told me I could use the photo. Okay, all right. So we had all these kids that are mixed with college kids, and it became this great environment. Because guess who they were doing the PACER test with? Other kids with heart disease. So they were doing the PACER test with their peers, cheering them on, parents up in the stands. This was like a stadium auditorium at the medical college that we used. And so all the parents were kind of up on the balcony, of course, holding hands and panicking a little bit, right? Oh my gosh, she's turning blue. And he's doing this. Yep, it's okay. And so what we did is we had them run together. And the kids were high-fiving each other. And they loved the social aspect of it. And we thought, we got something. We got something. So we had to, of course, publish this because this is part of what we have to do here. We had to tell you why we do what we do is important and why our research is important. So we published it, and we came up with some fun little results. We found that their exercise test at a 6-week follow-up and at 12 weeks both went up. But the good news is that when we left them alone for 6 months, we took away their mentor, we took away everything else, we must have done something okay because 6 months later, their exercise tolerance continued to go up. So we're very excited about that. And when we relate that to those measures of VO2, that mouse breathes in your mouth, we saw that those were consistently going up in most of our patients as well. So good news, right? We did something, it showed us a nice result. Our health-related quality of life inventory was kind of interesting. Our parents actually showed the greatest improvement in their perceived health-related quality of life for their kids. So my kids, I perceive them as doing better. They're more confident. They're doing better. But the kids, on the other hand, their health-related quality of life didn't change. And part of that, we guessed, we have no evidence of this, is that in some ways, we imparted a dose of reality in our kids. They didn't know what they could or couldn't do until we stressed them to do it. And then when they had that reality, in some ways it might have changed their perception first initially, where they're like, you know what, maybe I am not as good as I thought. Or maybe my health is not where I thought it would be. But then it was interesting because as we carried that out further, and we'll show you this when we talk about readiness to change, it got better. And they started to recognize what their abilities were. So our conclusions was that, first of all, it was safe and feasible. We were able to do this. It can improve the fitness level. That was something that was a bonus, right? We were excited about that. It can change parental beliefs. It can promote exercise participation. And it may create a more realistic health-related quality of life in children with CHD. Big conclusions, we can argue it. So now the big grand attempt. We said, we've done it. We've done these studies. A lot of people have done them. We got good results. We got some funding for it. We finally got the hospital to buy in and say, you know what? We're going to do the grand attempt. We're going to try stepping it up cardiac rehab program. And so what we did, stepping it up, is the Herma Heart Institute's cardiac physical activity program for children, adolescents, and young adults with congenital heart disease. We even came up with a mission statement or a goal. So we want to help patients feel better, get stronger. They will increase their endurance. They will regain strength. They will reduce their future health risk as they get motivated to stay active for the rest of their lives. Notice, stay active for the rest of their lives. We're trying to teach habits here, okay? So the program is led by a multidisciplinary team. All the important people right on the top. We got the cardiologist, our primary, and our rehab. What do we mean by that? Our primary cardiologist is a cardiologist that's taking care of that kid on a regular basis, the cardiologist that you see all the time. But we also have a designated cardiologist that runs our rehab program. Ronnie Jacobson was in charge of that, and now it's Dr. Joshua Kovach. Dr. Jacobson is taking her talents to Colorado and hopefully going to extend this program there. And we're looking at multiple centers to potentially do similar things as well. We have an exercise physiologist. We included a psychologist, physical therapy, occupational therapy, nutrition, all of these things. But then we really recruited the big hitters. And the big hitters are this, the patients and the families. What we did is we have these events that once every 6 to 12 weeks, we get all the families and all the kids in the cardiac rehab program together, and we host an event. Maybe it's at a performance enhancement place that specializes in training elite baseball players, and some of the major leaguers stop by and say hi to them. Maybe it's at the Marquette University where they get to do that. We have the student mentors from Marquette. We already talked about those. They're the non-threatening cool person. It's not the parent. It's not the doctor. It's not the people telling them what they have to do. It's people that are caring about them because they want to. And that's really, really cool. And then we've now been doing this for about a year, and our people who have graduated from the program, we'll show you a little graduation ceremony picture in a second. We thought, you know what? How powerful could this be? Let's let the people who actually went through the program, the people who have had the scars on their chest, the people who are going through the exact same things, they should be the mentors. And so now we're recruiting our own kids to mentor the kids that are in it. And so that's been really powerful too. Not a single one of them said, nope, don't want to be a mentor. Every single one of them was like, oh yeah. Because I remember how much I didn't like this at the beginning. And they're helping the other ones who are feeling the same way. So the design, they will participate in the Steppin' It Up program. It is a one-year program. It advances through 3 tiers. We'll go through that in a minute. We have these support group activities. We actually created a DVD. We didn't call Beachbody. We didn't use P90X. We didn't do this. But we did actually put together a group of kids, and we actually created an hour-long video that they can plug into their DVD and do it. It's got a mix of aerobic exercises as well as strength exercises with a warm-up and a cool-down. Worked really, really well until they watched it for about the 5th time, and then they said, this is boring. Right? Now I'm watching the same thing over and over again. And we are now trying to digitalize some of our workouts to make it a little easier access and change it up so they can pick and choose. So we're trying to make that a little bit more creative. What are those tiers? Tier 1, we want to develop habits. Makes perfect sense, right? We want to give them knowledge about why exercise is important. If we impart a desire to want to do it and we give them the skills to do it, then we think that we can develop a habit that will carry on. That's our first 3-month goal. 3 to 6 months, we teach them to make choices. Now they're starting to impart. So I don't tell them what they're going to do anymore. They now have to give me goals. This is what I want to accomplish. This is what I want my next goal to be. I give them a challenge. You have to invent an exercise. You have to bring it back to me. I will name it after you, and I will put it in the book. Right? So we've got the Jimmy, right, which is this funky, I don't even know what it is. It's something really cool, though. Can't do it. 6 to 12 months. The last thing we do, right, is we want to enjoy their community. Because at 12 months, we're going to let them go. We're going to, they're forever going to be a mentor. They're forever going to be a part of the program. But we're not going to see them anymore. And so if they live in Racine, we find community centers. We find areas there within their community that they can use as resources. Parks, available things like that. So we give them an activity pyramid. It's pretty straightforward. We designed it where green are things that they can do every day. We put it into kids' things, right? We don't think about working in the garden as work, but it may involve a lot of actual squats, upper body movement, things like that. Our yellow goal is 3 to 5 days a week. It's typically aerobic activities, things that make your heart beat faster is the way we describe it. 2 to 3 days a week, we do what we call strength training. We want them to be stronger. Stronger legs, better venous return, better movement, all over. And then the red. It is not a stop sign. It is the cherry on the top, right? If we do the other things, then we can enjoy being lazy sometimes. Don't lie. We all love it, right? We all like the cherry on the top. But if we don't know what else to tell them, right, we give them examples of lots of daily activities that they can go through, checklists. They can make their own. They can pick things. It can be anything from joining a club, picking up karate. It can be doing all this stuff. And obviously, with the consent of their physician who's given them clearance to be a part of this program. So we have all these very kind of cool and innovative ways to keep them motivated. So, Steppin' It Up program in the first year, we had about 21 kids come through it. They did well. I'm not going to bother you with all the results, but the bottom line is that they did pretty well. We saw an increase in their shuttle run, very much like we did in our rehab program, although not significant, but it was going up. It was trending in the right direction. And then we saw some readiness to change things that were improving in both the parent and the child, which meant that at first, when we were proposing this idea to them and we were trying to create that habit, there was some resistance to that, right? And then once they start to buy in, it's like anything else, we start to prove that it can work and we start to prove that we can be there for them and it starts to move forward. So this is a graduation ceremony that we had. This is one of our graduates. We play the Olympic theme song when they march in. We give them medals. There's a company called Medals for Medals. So if you've ever done a marathon, if you've ever done anything, and you don't want the medals sitting around your house, you can give the medal to this company called Medals for Medals, and then they give those medals to kids. And they get a certificate that says, I did really something very, very cool, and now I want to recognize you for doing something really, really cool, which is surviving with a congenital disease or fighting through something that most people would have to not fight through. We did find in our assessments that there was some incidence of greater than 50% in some mental health diagnosis, whether that would be depression or some anxiety, which those are the focus of other talks that we've already heard today. PTOT issues, tight muscles, tight hamstrings, things like that, no adverse events. And we did have 4 patients who, 2 of them withdrew from the program due to social issues and 2 from insurance issues. So I've got just a couple more slides and I'll finish up. This is some sample data from one of our patients. We recruited her in March, you can see. She was doing pretty well. This is her step counter. Her goal was 10,000 steps a day. She was a high school junior. And once high school ended, you can see in June, it got real convenient to be lazy. Right? So what we did here is this is a perfect time to intervene because we have this big community of all this Fitbit data, and we recognized there was a lull. And then we intervened and we said, hey, what's going on here? It's getting boring. That's fine. We can redo something. We can change something. Our mentors would step in. And then, of course, summer ends and school starts again, and all of a sudden, depending on the activities and things. Or it just could be cyclical. And this could be very different for each kid. But those low points are an opportunity for us to do. So what does it all mean? Well, it means that I think this might work. I think that this has a chance, right? I think that if we get the right people involved and we get some hospital buy-in, and we understand that we're not trying to make money with this program, but we are in some ways trying to change lives, then I think that there's some significant improvement in things that can be done. Exercise capacity, readiness to change, all of these other things. And if we can incorporate different interventions, we can figure out why a kid doesn't like to exercise. So instead of just constantly telling him he needs to do this, before we recognize the barriers to making him do it, then all of a sudden, we didn't solve the problem. They may never be a successful exerciser if there's major barriers that keep them from doing it. Fear, anxiety, depression, issues, right? All right. So, my acknowledgements. I have to acknowledge Marquette University for giving me this. I have to acknowledge you guys for letting me come talk, right? That was really cool. You didn't have to do that. I have to acknowledge Children's Hospital because they've been basically letting me play with kids for the last 15 years, right? And I get a paycheck, which is pretty sweet, right? All right. And so when it's all said and done, I will never tell a kid to do something that I won't do myself. And I tell that to the parents all the time. If you want your kid to be active, play with them. If you want your kids to go outside with them. Be a part of this activity. And I know it's tough, but you'll enjoy it and you can spend some more time with it. So with all that being said, it's all about just making it to the finish line. I guess we're falling from a cliff. So the video played sideways. So anyhow, that's all I've got. Thanks for giving me your time.
Michael, don't go too far.
Oh, okay.
We have a wonderful gift for you. I'd be scared. I don't know what's in there. I don't know. Thank you so much. We appreciate it.
Well, great.
And we have just discovered that we have several questions. So what we're going to do is we are going to open it up on our coordinator site. So if you have the national site, so if you have any questions, I want you to write them down and then we'll post them to that site and then they'll be able to answer that.
So post now on the national Facebook page, just write them right on there and we'll get them answered for you. We'll try to get some of them answered while we're here.
Okay.
In a very quick time of year. All right, thank you again. Our next speaker is Cynthia. Come on down, you're the next contestant. Always want to be on Prices Right. Right? We would be good at it. Welcome. Thank you. This is Cynthia. She is the Director of Education and Training. Cynthia is responsible for overseeing the varied training programs for the trainees, including the Postgraduate Social Work Fellowship and staff at the Mended Clinic, one of the nation's top-ranked psychiatric hospitals. She serves as a supervisor to postgraduate fellowship candidates and entry-level social workers towards advanced licensure. She's also a senior social worker who provides individual therapy, psychosocial assessments, family therapy, and aftercare planning. Please welcome Ms. Mulder.
Thank you.
Okay. Thank you so much. Jody actually asked me to come because I'm also, in addition to being a social worker and a therapist, I'm also a member of the senior faculty for Brene Brown and her curriculum on the Daring Way. How many people know Brene's work? A few of you, okay. She is so I'm going to talk a lot about her work in addition to the work that I do at the Mended Clinic. And I'm going to be talking primarily to you as parents. That's sort of who I work with. I work with a lot of adults who are struggling with depression, addiction, trauma, anxiety, eating disorders. And so what I'm going to hope to do is translate some of what I've learned through my work that I hope will be helpful to you all as we try to tackle this idea of cultivating a resilient spirit. So it's afternoon, so I wanted to have a little humor. This is my favorite slide, which is, Lassie gets up, and then Lassie ends up on the psychoanalytic couch. So in order to cultivate a resilient spirit, one of the things that I've learned and we know is that we have to have an understanding of the role of shame. And so in order to build resilience, we have to know where shame shows up in our life. And if you can take anything away today, it might begin to have a curiosity of sort of being a detective to where shame shows up in your life and maybe where shame is going to show up in your child's life. We're also going to talk a little bit about the importance of empathy and self-compassion, and then also how important it is to be able to talk to somebody about painful issues that you trust. And one of the things that I've learned is that to actually reach out and ask for help is profoundly difficult because it requires vulnerability. And oftentimes the people that I treat have waited so long to ask for help that it becomes a crisis. And so hopefully we'll be able to tackle some of that. So one of the things that we know about shame is that people used to believe that they could shame you into change. And so this little picture of a person with a dunce cap, it used to be that if I could say you should be ashamed of yourself, that might motivate somebody to do better, to study harder. And what we know is that the research shows that that actually is not the case, that shame is not motivating. We also know that shame is not present at birth. We come into this world and we don't know a lot about shame, but then we learn about it through caregiving, through parenting, religion, schools, relationships. And one of the things that happens is that it starts off as a two-person experience, meaning I learn about it through another person, but then actually I don't need anybody else. I can shame myself quite powerfully and profoundly. And so in order to build resilience, we have to know where this is showing up. And we also now know that shame is highly, highly correlated to many of the issues that bring somebody into psychological or psychiatric treatment. So depression, as I said earlier, depression, addiction, eating disorders, trauma, bullying, you name it, shame is highly correlated. And oftentimes when I ask the patients in my group, how many of you have ever had a conversation about shame? Nobody raises their hand. So I ask you, how many of you have ever had a conversation about shame? We've got 4 out of this room. So this is part of what our work is. So one of the things we know is shame is driven by silence, secrecy, and judgment. It leads to profound isolation and disconnection. And one of the things we also know is it's so interested in staying hidden and concealed that oftentimes it even doesn't come up in a psychotherapy session. But it's experienced as overpowering, it's visceral, we have a physical experience, and it evokes this sense of badness, that we're worthless, we're contemptible, we're unlovable, we're inadequate, somehow we're flawed. And so it can make us feel like we're shrinking, being small, somehow feeling exposed and wanting to disappear. And what we know is that our bodies actually react to shame before our brains come online, because shame is processed in the body where trauma is processed. So when we have traumatic experiences, our ability to actually think through those become quite compromised, because shame is processed in that kind of reptilian part of the brain, not this prefrontal cortex where we're more organized. And so Brene Brown interviewed over 13,000 people and asked them what their definition of shame was. And this was out of 13,000 interviews. they define shame as the intensely painful feeling or experience of believing that we're flawed and therefore unworthy of love and belonging. And one of the challenges is that it is a universal emotion. We all have it. And yet the second issue is nobody wants to talk about it. And the more that we don't talk about it, the worse it becomes. And so to be able to sort of define it, to find out where shame shows up in your life, becomes the path towards resilience. And this slide looks at some of the areas that you may experience shame. So right at the top is mental health and physical health. And so having a physical illness can be an elicitor of shame. It doesn't have to be, but it can be. Having a diagnosis of depression or struggling with anxiety can also be an elicitor of shame. And one of the things that we know is it also changes over the course of our lives. And so when we're in our youth, what is shaming is different from when we get older. And so where we can figure out where it shows up and then how it overlays can become quite powerful and profound. And so oftentimes when we're thinking about building resilience to shame, we have to think about the other emotions that get used interchangeably. And the first one is embarrassment. And embarrassment is oftentimes used interchangeably, saying I'm ashamed, but actually embarrassment is fleeting and funny. And we know that somebody else in the world has had this experience. So how many people have ever had spinach in their teeth? Show of hands. Okay. How many people, when you trip, what is the first thing that you do? Laugh. What's the second thing you do? You look around to see who else has seen me, right? And if nobody has seen me, we usually move on from it. So the second, what we call emotion of self-conscious affect, is humiliation. And that is when something undeserved happens and it evokes anger in us. We can feel that, and how it differentiates from shame is that we talk about it because it made us angry. So if something, you may have the same physical reaction, but you're going to speak about it and say something to the effect of, you're not going to believe what just happened to me because you believe you didn't deserve it. Then the next emotion that oftentimes gets confused with shame is guilt. And guilt we think of as a focus on behavior. I did something wrong. I made a mistake. And if I can make a mistake, then I can apologize and make amends for it. But oftentimes when people start apologizing and continually apologizing, how many people have ever heard somebody sort of keep apologizing repeatedly and relentlessly? I would suggest to you that's more associated with shame. Because if we make a mistake, we say we're sorry and we move on, then that's about guilt. And the goal is really to be more guilt prone. But shame, we focus on the self. We feel we deserve whatever has happened, we believe we're bad, and then we stay silent about it. And so that is what leads to self-destructive behaviors. So the fact that you are all here at this conference, in a way, you are building resilience in vivo, because you're saying, I don't want to be alone with this struggle. I want to make connection with other people. I want to understand. That's about resilience. But that may have taken some time and some steps to get here. So these different things, embarrassment, humiliation, guilt, and shame, oftentimes when we can help somebody understand that and we can help our children understand it, it again can lead to more resilience, because then we're at least talking about what the emotion actually is. And oftentimes as a parent, you will learn about something because a child feels humiliated. They'll come home and tell you about it. But if it's shame, they oftentimes won't tell you about it. Does that make sense? So we also have, I'm going to talk a lot about shame, then I'm going to move into resilience, so bear with me for a little longer. So we have universal triggers. And the first one we think about is this concept of scarcity, meaning that we are not something enough. You fill in the blank, okay? It could be that you're not thin enough, you're not able enough, you're not rich enough, smart enough. Whatever that blank is, that will be an elicitor of shame. And also comparison. Comparison is a very, very difficult, clever foe, because it usually leads us to feel more depressed and more dissatisfied with ourselves, because we don't typically compare to somebody else and then feel good about ourselves. We oftentimes compare and then feel like I didn't measure up. And so even if you're feeling pretty good, you might look towards somebody else and think that they're doing it better, and that can be an elicitor of shame. And then the final elicitor is what we call unwanted identities, and we all have a desire to be viewed in a certain positive way. And if we have any whiff or hint that somebody is seeing us in a way that we don't want to be perceived, then that can be an elicitor of shame. And parenting is sort of a shame minefield. Does that make sense? I mean, you're sort of constantly comparing yourself to other parents, and so it can be quite challenging to be centered in yourself and feeling that I'm doing the best that I can. So we have these shame triggers, and then we have ways to try to protect ourselves. And so a big way that we protect ourselves is by numbing. And so we as a culture today do a lot of numbing. We numb with food, we numb with alcohol, we numb with work, we numb with the internet. You know, binge watching Netflix is a new form of numbing. Facebook. And when we feel powerless, we can also really start to numb. If we feel helpless, we can start to numb. It's about disconnecting from ourselves. And shame is also about that disconnection from the self. Another form of armor that I think is really powerful and complicated is this concept of called foreboding joy. And what this means is that if we are enjoying a moment, if we have a reprieve, if we have a moment of feeling like things are okay, we cut that off and start dress rehearsing the next tragedy. We start thinking catastrophically. It's sort of the antithesis of mindfulness. And so if you're feeling like, wow, we're doing okay, we're making progress, in that moment you stop and you think, oh God, what bad thing is gonna come next? Does that make sense to folks? And I think how many people do this foreboding joy? And so if we can become aware of it, then we can begin to do something different. And then a final way of armoring up is perfectionism. And so shame is the birthplace of perfectionism. And this is oftentimes why it's also linked to parenting, because there's this idea if I can be a perfect parent, then everything will be okay. How many perfectionists are in the room? Oh my goodness, there are only 4 of us. Okay. So I love these 2 quotes from Brene. Perfectionism is a 20-ton shield with an effort of protecting ourselves from experiencing pain, hurt, and vulnerability. If I do it perfectly, I'll avoid feeling shame. And then this other one, which is when perfectionism is driving, shame is riding shotgun, and fear is that annoying backseat driver. Right, so when we get on the perfectionism train, we've also lost our connection to ourselves. So 1 or 2 more slides on shame. So when we're in shame, because we process it in the limbic system, as we do with trauma, we think of it in the fight, flight, freeze dynamic. Has everybody heard of that pattern of fight, flight, freeze? Okay. So when we're in shame, some people, when they're feeling shame, respond with aggression. They may lash out, they may blame other people, there may be some kind of violence or self-harm, suicide. They may also take it out on themselves in a form of tremendous self-hatred and self-loathing. And sometimes when people are in shame, they connect with the flight aspect, which is then they just avoid. They disappear, they disengage, they've checked out. And then for some people, in terms of the fight, flight, freeze, they use what we call this sort of people pleasing, where they say yes when they really want to say no. How many people have ever overly said yes to when they don't really want to do it? Okay, after you do that for a while, what happens? How many people start to develop a resentment? Yes, and then we move into the fight, the moving against. And then we might feel bad that we've moved against, and so then we disappear and we've moved away. And so these strategies are strategies to try to manage shame, but actually then lead to more disconnection and shutting down. So here's my little ginger person of the cycle of shame. It gets triggered internally, externally, activates the limbic system, we react, we use these shields, and then we feel worse about ourselves. So if we're going to develop resilience and cultivate a resilient spirit, we have to figure out when we're in it. What triggered it? Pause. The pause button has to be your best friend to not make the situation worse. and sit back and get some kind of perspective and challenge, I'm the only one, because shame wants us to believe that we're the only one, fill in the blank. And so if we can identify people we can talk to, that's incredibly important. And also practice self-compassion. How many people are really good at self-compassion? That would be no hand in this room. So here is the beginning of your work then, is cultivating a practice of self-compassion. And that's not unusual. When people have high levels of shame, they have very low levels of self-compassion. And so that whole the mantra of putting the oxygen mask on yourself, this is another moment of having to put the oxygen mask on yourself before your loved one. So the antidote to shame is empathy. And empathy is the ability to perceive a situation from the other person's perspective, to hear, feel, see your unique view of the world, not my view, your view. And when I do that, I have to take your perspective, I have to stay out of judgment, I have to recognize emotions and really communicate my understanding of what you're feeling, and then mindfulness. And this website, the bottom here, self-compassion, the ability to be kind, non-judgmental to ourselves, www.self-compassion.org, is the website of a researcher out of UT Austin called Kristen Neff. And you can actually take a self-compassion quiz, which usually is an elicitor of shame because you'll get a low score on your quiz. But if you practice self-compassion in about 6 months and you retake this quiz, you'll probably see some improvement. And it has wonderful, wonderful exercises. And I love this quote. This feels a little hard because post-Harvey, but if I share my shame story, will this other person be a piece of flying debris in the storm? Or are they like the sturdy tree firmly planted in the ground? When we share our stories of pain and struggle, we need people who can be a firmly planted tree. If they become a piece of flying debris, that's not empathy. Then you're most likely going to be taking on and trying to attend to their upset, and that's not being empathic. I'm going to skip the video, but if you Google search Brene Brown, empathy, there's a little short video of a wonderful little clip. And if you Google search Brene Brown, blame, for any blamers, you get the link between shame and blame. And they're all on YouTube. And she has a couple other TED Talks that are fabulous. So if we think about resilience, it's the ability to recover from difficulties, the ability to bounce back. I love this one from the American Psychological Association, which is the process of adapting well in the face of adversity, which can be trauma, tragedy, threats, stress, all of the things that you as family members are under all the time. And so how do we have resilience? How do we adapt well to something that is sort of incomprehensible? So one thing is we have to be really clear of our values, what really matters in the deepest of our hearts. The more we're clear about what really matters, that will help us develop resilience to shame. Shame pushes us away from what deeply matters. And so then we may do things, say things that then feel disconnected from ourselves. And to be really clear about what matters brings us back into alignment. We also have to reckon and rumble with a lot of difficult emotions. And so my sense is you all know this, but this is the role of psychotherapy oftentimes, which is how do we reckon and rumble with all of these emotions and have a space to understand them and to feel them and to work through them. And just one thing about vulnerability. So vulnerability, Brene talks about this extensively, and she has a TED Talk that's quite powerful because vulnerability is uncertainty, risk, and emotional exposure. And to be human is to be vulnerable. To have a child with a congenital heart disease is vulnerable. We are all vulnerable, and the more that we can talk about our vulnerability and reach out and ask for help, the better we're going to be. To ask for help is vulnerable, but the more we stay silent, the more we then stay alone in that struggle. And so this is the final slide. So this comes from the Brene's book, The Gifts of Imperfection. But on the, I guess it's your right-hand side, in the color, are things to cultivate, that cultivate resilience. So how do you cultivate authenticity? How do you cultivate self-compassion, this resilient spirit? Gratitude, how do you cultivate creativity? And on the left-hand side in the gray, these are all things that you would have to let go of. Letting go of what people think, letting go of perfectionism, letting go of numbing, letting go of scarcity, letting go of comparison, anxiety. And in order to let those things go, those are all linked to some trigger to shame. And the more you figure out where shame is on the kind of the gray side of the box of this picture, the more you're going to then be able to cultivate. So it's a dialectic that goes back and forth. And the bad news is that once you get there, it doesn't mean that you stay there. It means that you have to keep practicing and cultivating. And so this is, these are some resources that I mentioned, some of the TED Talks, the books. If you're interested in this, the website, The Daring Way, has a lot of trained clinicians who understand the work of shame and can talk in that language. And then also Brené's books. And if you have, if you're given the challenge of self-compassion, I also want to point out this resource of Christopher Germer. The book at the very end, The Mindful Path to Self-Compassion, has a lot of wonderful exercises and resources. Thank you very much.
Thank you so much. And we also want to let you know that the video has already been put on the national Facebook page. Before we bring up Michelle, I want to thank a couple people. Jody, don't go anywhere, just shut. This symposium, I'm sure you guys probably understand, takes a lot of time. And there's a lot of behind the scenes stuff that goes on. And it could not be possible without Jody and her fabulous team. So let's give her a round of applause, because without her, this would not have happened.